The following podcast is part of a certified educational activity titled The Future of Care in Postpartum Depression: Comprehensive Strategies for Early Diagnosis and Effective Treatment. Access the entire activity and complete the post-test at peerview.com/NCN860. Downloadable additional resources are also available.
Hello, I'm Dr. Christina Delagenides, the Director of Women's Behavioral Health at the Zucker Hillside Hospital at Northwell Health and Professor of Psychiatry, Molecular Medicine, and Obstetrics and Gynecology at the Zucker School of Medicine at Oxford Northwell in New York. Welcome to this educational activity titled The Future of Care in Postpartum Depression: Comprehensive Strategies for Early Diagnosis and Effective Treatment. You'll also hear from a patient who will share her experience with PPD, including her diagnostic journey and the impact that it has had on her and her family's lives. Our goals for today are to improve your understanding of the burden of PPD and the impact of delayed diagnosis on patients and families, to augment your ability to apply the latest clinical guidelines and validated screening tools to quickly identify patients with PPD, to increase your knowledge about the pathophysiology of PPD, including the role of endogenous neuroactive steroids and GABAergic neurotransmission in the expression of PPD symptoms, and to improve your understanding of the mechanistic rationale and clinical evidence supporting new and emerging pharmacotherapies for PPD. Let's get started with understanding the burden and unmet needs in PPD. It's important to know that the prevalence of perinatal mental health conditions, including postpartum depression, has increased in the U.S. over the past 2 decades. Recent data show that there's been a doubling of perinatal mood and anxiety disorder diagnoses in the past several years. We know that from national data, perinatal depression affects approximately 1 in 7 women, and the onset can vary, with some patients developing depression during pregnancy or the postpartum period. And for some women, they may have depression that had started prior to pregnancy and continues into the peripartum period. We know that anxiety disorders are very comorbid with perinatal depression. And most women, 2/3 of them with perinatal depression, will have one or more comorbid psychiatric disorders. So it'd be really important to try to understand the context of these disorders with perinatal depression. And we'll go over that a little bit more when we discuss screening and diagnosis. Also, we know that women with a history of postpartum depression are at 27 to 46 times more likely to experience postpartum depression during subsequent pregnancies. So another clinical pearl to ask about is a history of prior depression and postpartum depression. We also know that about 70% of women with a pre-existing mood disorder who discontinue their antidepressant in pregnancy will experience a relapse of major depression. So just a key statistic in knowing how important treatment during the peripartum period really is. Data also show that African American and Hispanic and Latino women are more likely to develop and or report PPD symptoms compared to white women. However, minority individuals and those who live in rural areas and have Medicaid insurance may be less likely to receive adequate postpartum care compared to those who live in urban areas and have private insurance. So these are some significant racial, ethnic, and sociodemographic disparities in both diagnostic rates and the management of PPD. And there are many consequences of untreated PPD. There are adverse events for mothers with untreated perinatal depression or postpartum depression, but also their offspring. And so let's look for the mother first. We know that for patients with untreated PPD, there's higher risk of substance use, relationship difficulties, suicide ideation and suicide attempt, or completed suicide, but also fewer positive interactions between mothers and babies. Mothers may have less confidence in feeding their baby, and some of their parenting behaviors may be less attentive, especially regarding safety measures. For the offspring, so for exposed infants and children, we know that there is much data now that show poor neonatal outcomes, and these can include increased rates of stillbirth, preterm birth, fetal growth restriction, small for gestational age, and others. We have many years of data that show increased rates of insecure infant attachment, sleep disturbances, lower IQ, slower language development, and behavioral problems. These children are also at an increased risk for the development of future psychiatric illness. Also, not to be forgotten, the partners of women with postpartum depression experience increased levels of stress, anxiety, and depression. And overall, unresolved PPD symptoms impose a significant economic burden on society due to increased healthcare costs for the patient with PPD and others in their household. We also know that in their most severe forms, perinatal mental health conditions are a tragic and preventable cause of maternal mortality. Suicide, overdose, and poisoning are the most common causes of pregnancy associated maternal mortality, as determined by maternal mortality review committees. And many of these deaths occur in the postpartum period, up to the full year after birth. Now let's take a minute to hear from a patient with lived experience with postpartum depression.
So I had postpartum depression and postpartum anxiety. The anxiety part was through the roof. And the depression stuff was definitely there. Like 2 weeks after he was born, it hit, and it hit hard. So I think that was kind of where it started. And like, the post birth hormones are nuts. So I feel like that's really what started triggering it, like a flare up of depression. Like I don't want to do anything. Like I go to school and I'm able to do my job, and I come home and I sleep. Like I'm spent, I'm useless. I have no motivation to do any of the things that I love. I'm really snappy with my husband. Like I just kind of like retreat into myself and into my bedroom. I firmly remember we went out. He was 2 weeks old. My parents watched him so we could go out and just like at dinner and have a couple of drinks and some oysters, things I couldn't have while I was pregnant. And we were driving home, and I'm like, I don't want to go home. I didn't want to be around him. I didn't want to hold him. I didn't want to touch him. I didn't want to look at him. And my husband is like, okay. So he is and will forever be Mr. Fix-It. So he not that he didn't step up before, but he extra stepped up and really tried to make sure that I was getting enough sleep. And he would force me to hold my son to make sure that I wasn't completely avoiding him, while also trying to give me space. But that feeling of I don't even want to be around him. That's when it really set in, and I was like, this is not normal.
Now let's turn to identifying PPD in our patients and how to determine when it's more than just the baby blues. There's a significant role for OBGYNs in the detection and management of PPD. We know that approximately 1/3 of all physician visits for adult women are with an OBGYN physician. And many women report that their OBGYNs are their only source of routine health care, and that they are their preferred providers for mental health treatment when they experience symptoms of PPD. The American College of OBGYN has many recommendations based on their recent update to their clinical practice guideline published last year. They recommend that OBGYNs and other obstetric care providers should screen patients twice during pregnancy for depression and anxiety, and to use a standardized validated tool. Also, OBGYNs and other obstetric care providers should complete a full assessment of mood and emotional well-being during the comprehensive postpartum visit for each patient between 4 and 12 weeks after delivery. We'll talk about this a little later as well. Let's define postpartum depression. In psychiatry, the DSM-5 has the following diagnostic criteria, and the official diagnosis is major depressive disorder with peripartum onset. So this is clinical depression. It's the same diagnostic criteria for major depressive disorder outside the peripartum period, but the specifier of peripartum onset notes that these symptoms occur during pregnancy or within 4 weeks after childbirth. However, other professional organizations utilize a longer period in the postpartum to define postpartum depression, with many defining this up to a year postpartum. As you can see, depressed mood, diminished interest or pleasure, a change in weight or appetite, insomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, and recurrent thoughts of death, suicidal ideation can be present and have to be present during the same 2-week period and represent a change from previous functioning. So 5 or more of these symptoms should be consistently present nearly every day during that same 2-week period. And assessing functionality, the patient's impairment, is very important to this diagnosis. Here's a nice way of thinking about how to differentiate clinical depression, or PPD, versus the baby blues. So we think of the baby blues affecting the majority of mothers. It's about 85% occurs within a few days after delivery. It can last a few hours or a few days, but will remit spontaneously within 2 weeks of delivery and does not require any treatment at all, responds and resolves spontaneously. The symptoms are typically mild, and the important differentiator is that functioning is not impaired. For postpartum depression, this can affect about 13% of mothers, and it can occur anytime in pregnancy, but especially in the 3rd trimester and within the few months after delivery. It lasts longer than 2 weeks, and if not treated, it can last up to 3 years or longer. You will see functional impairment in this diagnosis, and it requires treatment. And clinically, as noted, the risk of postpartum depression dramatically increases if that patient has a history of major depression or starts to have symptoms during pregnancy or has a history of PPD with a prior birth. Now let's discuss screening for PPD and other mental health concerns in the peripartum period. The Edinburgh Postnatal Depression Scale is especially common for screening for depression in the peripartum period. It's a 10-item self-report, again, validated across the peripartum period. It's simple to score, and it's available in more than 50 languages. It does consider both depressive and anxiety symptoms, but what's nice about it is that it doesn't measure some of the somatic symptoms that could be associated with pregnancy and delivery, such as sleep and also energy. There are different cutoffs, but the cutoff of 12 or more yields sensitivities and specificities from 80 to 90%. And then when you look at the form, question 10, that final item, assesses suicidal ideation and should be given consideration independent of that total score. So always check question 10, even if the patient doesn't meet that cutoff score that your practice is using. It is more accurate of identifying women with and without depression than the PHQ-9 or the postpartum depression screening scale, but each of these is acceptable. Also important to know that an elevated score may not be specific to unipolar depression. So it's a great screening tool, but it just can't be used diagnostically. However, this scale has been validated and administered in diverse populations, making it an excellent choice for screening. So what happens after screening? So for patients who screen positive, then there has to be additional diagnostic assessment. So things to clinically ask about are severity and duration of the symptoms, the functional impairment, really understand if they've had a past psychiatric history of depression, anxiety, hospitalization, or medications, and the family medical history as well, to rule out other causes or other diagnoses, and also to fully understand the current risk. There's some laboratory testing that can be done, including thyroid evaluations or to rule out anemia, but then also to use screeners for bipolar disorder, so to be able to screen for mania or bipolar disorder, and to assure that there are no current symptoms of psychosis like hallucinations or delusions, which might point to a much more serious psychiatric illness that would require referring that patient to a psychiatric provider. Also, we do want to assess, because of the comorbidity that depression has with anxiety, to inquire about anxiety, obsessive compulsive symptoms, especially obsessions around the baby, but also if the patient has a history of panic, or certainly screening for substance use symptoms as well. And then, as we're going to discuss, to be sure that we do a thorough suicidal risk assessment, which we're going to talk about in a short period. And then, to schedule the follow-up to monitor symptoms and to, in a validated way, monitor that treatment response by continuing to use those screening tools to see if the score is going down with treatment. Now, ACOG did recommend screening for bipolar disorder, either by asking about family history, but if starting an antidepressant, to administer a screen for bipolar. This is one of the more common ones used, and it is publicly available. It can be handed to the patient. It is a self-report, and they just fill in the bubbles, yes or no. On the reverse of this questionnaire, it instructs the clinic on how to score it. And so if they have greater than or equal to 7 yeses on the 13 items listed, that would be positive. If they have 2 or more co-occurring symptoms, and if the symptoms really are causing a moderate or severe problem. This is really important because it lets the clinician know which one of the patients may have bipolar disorder or may need a higher level of psychiatric clinical care. The other thing that changes risk assessment is that suicide risk. And so depending on which tool you're using, many of them will have a probe. And if there is a positive screen, then ACOG recommends trying to assess a few additional items. Now, there are many tools available, and ACOG doesn't tell us which tool to use, but this is one that was developed by the National Institute of Mental Health and is used widely in primary care settings. It has the exact questions that can be asked with the exact wording so that it's very clear to the patient. It's a series of 5 yes or no questions. And then it has clear next steps for the clinician. So what is a positive screen? What is a acute positive screen or non-acute positive screen? What is a negative screen? And how to follow up. The American College of OBGYN also recommends that within this assessment, we try to understand about the suicidal thoughts, the plan, the lethality, and the needs, because this really helps us determine the risk, right? And that determines sort of how we triage the patient and how do we get the patient the appropriate level of care. And so it'll be clear, but low risk patients don't need to go to the emergency room, right? So we want to make sure we have the appropriate assessment, and then that's going to match what the follow-up's going to be. So there might be some patients with mild depressive symptoms. Maybe they have fleeting thoughts of not wanting to wake up in the morning or thoughts of self-harm, but there are no current plans. They have no means. The thoughts aren't sticking with them. They really just come and go, maybe at times when they're stressed. So obviously we want to discuss support and treatment options. We're starting treatment. We've diagnosed depression. We want to arrange follow-up for that with us, the OBGYN clinic, but then also with therapists in the community or a psychiatrist, depending on what the needs are for that patient. Then for, what we would consider medium risk, perhaps there are some suicidal thoughts. The patient expressed at times she wants to die, but has no plan, has not thought about a plan, has no immediate access to anything with which she could take her life. Again, we're initiating treatment, discussing support. We're developing a safety plan with the patient and the patient's family or trusted person in their family or in their social network. We're reassessing within a week. We're having a contingency plan in case things are worsening for that patient before that 1-week follow-up. So if these symptoms increase in frequency, we need to have your aunt take you to the emergency room or your spouse take you to the emergency room, things like that. And then a little bit higher risk, if there's any kind of plan of self-harm or harm to others, that is where we have an urgent transition to psych ER, the emergency room, where a psychiatrist can assess suicide risk. That is usually within an emergency room setting. Some settings can do this with crisis clinics, depending on what is near to you. And obviously, we also have to assess the risk to the infant in any of these situations as well. So we kind of put it all together. For mild symptoms, the scores are going to be lower on the depression or anxiety scores. Usually we don't see suicidal ideation. We don't see hopelessness or helplessness. We may see some functional impairment, but not severe impairment to the patient's activities of daily living or their ability to care for the infant. With moderate, we see those scores going up a bit. So the EPDS scores could be 15 to 19 in that range. Sometimes we will see passive suicidal ideation at that level of depression. feeling that they'd be better off dead or that their baby would be better off without them. Those are things that we hear clinically. Sometimes you'll hear that the patient has periods of hopelessness or helplessness. When you see more functional impairment, then as the disease is more severe, you start seeing those scores over 19 on the EPDS, so over 19 of a possible 30. And then you more often see suicide ideation. You could see more persistent feelings of hopelessness, helplessness, or worthlessness. The patient sometimes is very clear, says she's really having a hard time taking care of herself, showering, taking care of the baby, things like that. So we really, in all of these situations, want to start treatment. We want to make sure we're doing a good review of systems to rule out any other medical conditions that could be worsening the situation. But starting treatment is really critical. At what point do obstetric providers then refer to mental health specialists? I would say when there's diagnostic concerns, when there's multiple psychiatric comorbidities, you have a patient with numerous psychiatric hospitalizations or suicide attempts, maybe there's treatment resistance, any safety concerns, you really want to develop a referral network in place in your practice that includes a variety of mental health professionals that are local, that have experience working with peripartum women, and know that you're able to refer in a reasonable amount of time to be able to get them into treatment. Ideally, we want to start treatment in the OBGYN clinic as we're making plans to transition to behavioral health. We don't want to delay treatment and then wait 3 months for that patient to get connected with psychiatry, because then that is just exposing the patient, the baby, the family to the ill effects of PPD. And then also we know that we want to make sure there's warm handoff so that not just handing a patient a slip of paper with lots of referrals of people who might be taking their insurance or might speak their language or might have an appointment in the next 2 months, but rather actually making sure those patients are connecting to care, make sure there's follow-up. If they're not connected, keep trying to make that appointment happen. Now let's discuss advancing insights into PPD management. And the way I'm going to approach this is discussing a little bit of the neurobiology and some of the novel FDA-approved medications for PPD. So the brain is made up of numerous circuits, and GABA is the main inhibitory neurochemical. Glutamate is the main excitatory neurochemical. And this balance across the circuits is really important for maintaining homeostasis and not having psychiatric symptoms. And so looking at the depression literature, we see a lot of direct evidence of GABA's role in the development of depression. That includes alterations in concentrations of GABA, but also decreased expression of GABA synthesizing enzymes, altered expression of GABA-A receptor subunits, reduced number of GABAergic interneurons, and polymorphisms in GABAergic genes. And also, there's been more recent work within postpartum depression of GABA's role in the regulation of particular networks that are really important for emotion regulation in the brain and are abnormal in women with postpartum depression. And decades of data that has shown GABA's important role in regulating the stress response. Remember, that's the hypothalamic pituitary adrenal axis. And these endogenous neuroactive steroids, which can include allopregnanolone, which is a metabolite of progesterone, have really important roles with GABA. They're rapid and potent allosteric modulators of the GABA-A receptors, and they bind two types of receptors, both synaptic and extrasynaptic. These neurosteroids, such as allopregnanolone, play a really critical role in stress regulation in the brain, both in non-stress and acute and chronic stress conditions by activating GABA. And so in peripartum period, we know that these neuroactive steroids go up during pregnancy and come down in the postpartum period. And here, both progesterone and allopregnanolone levels are changing across this peripartum period. And the receptors, these GABA receptors that bind the neurosteroids, also have to change. So they're changing during pregnancy when the hormones are high, and they're changing again when the hormones are low after delivery. A lot of data now is indicating that there might be an abnormality in the brain's ability to adapt to these hormone levels, and that it might be at the level of the GABA-A receptor. So that perhaps for some women that have a trigger of depression during these hormonal changes, their GABA-A receptors are not adapting to those hormonal changes. And well, what does it mean if they're not adapting? Well, that throws off the circuit and that balance of GABA and glutamate. So we know in what we call a euthymic mood state, you need to have a balance of inhibition and excitation. But with stress, we know that that balance can go off so that we have excesses of glutamatergic transmission. And that can actually lead to defects in GABAergic transmission that can exacerbate stress. With chronic stress or defective GABAergic functioning, then we can have a mismatch of GABA and glutamate, which looks even lower. So the levels are balanced, but the synapses remain impaired. And that can explain some of the brain connectivity that we see in depression. Based on preclinical data, we know that by providing GABAergic positive allosteric modulator, such as brexanolone or zuranolone, the two FDA-approved medications, that this restores the balance between GABA and glutamate back to the euthymic state. And now let's hear from a patient with lived experience of PPD.
It took a little bit, so it wasn't like a instant, as we all know, like they take some time to work. So I started on a lower dose. Well, like I was on like the dose that I'm still on now. And then she's like, okay, like clearly this dose isn't working. So I was on that dose when I started the program. She's like, okay, so why don't we up the dose? So we went up to the next dosage, and like I felt a little better, but I still didn't feel like it was fully helping. So then I did the highest, or the high, not highest, but higher dose of that medication plus another medication. So I had two medications, and then I worked up. I think I started at 10 milligrams on that additional medication. I think I worked up to like 40 at one point. So, like being on the medication, like I could start to enjoy spending time with him. And like I wanted to go see him in the nursery, which was not the first, even though I was like having to take care of him the first week. Like if I could have left him in there, I would have left him in there. But like I wanted to go in and see him, and I wanted to like check up on how he was doing. And like I could feel that, like I feel like when this whole thing started, like I just didn't like know what to feel. And then as I did the program and as I like found the right dosage of meds, like I wanted to start being his mom. Like I wanted those things for myself.
Let's discuss some unmet needs in the management of PPD. And so I'll start off with all levels. So mild, moderate, or severe PPD. We always want to discuss with our patients the importance of sleep protection, physical activity, psychosocial support. But for mild depression, we also want to start talking about psychological treatments. We also want to manage social stressors, any medical comorbidities, really across the board. Now, when you reach just more of a moderate to severe level, in addition to all of these things, including psychological treatments, we then add a pharmacotherapy. So traditionally, that has been a selective serotonin reuptake inhibitor. And then in cases where the depression is severe, usually we're utilizing, again, a combination of an antidepressant plus a psychological intervention. But at that point, we might need to augment or change the medication if the patient is not responding to that pharmacotherapy. And then in some cases, we could consider alternatives to pharmacotherapies, including neuromodulation, which may include ECT. Now, traditionally, I would say the conventional use of antidepressants prior to the FDA approval of PPD specific antidepressants was really the use of monoaminergic oral antidepressants. And those have been the standard of care. But there have been some limitations as well. Not all patients respond to SSRIs or SNRIs. And then with the onset, there's a delay in the action of these medications. And it can be 4 to 8 weeks for patients to have a response. Part of this delay is also that many of the medications require a titration, right? So there's an up titration involved that itself can take several weeks until you get that balance of efficacy and tolerability. We also know that improvements in functioning and quality of life, those can tend to lag behind the initial symptomatic relief. And so sometimes the patient's waiting to actually, quote unquote, feel better and be able to function better. But even though they're starting to feel less sadness or feel the resolution of other depressive symptoms. And then because the conventional serotonergic antidepressants are given in a chronic way, we know that the side effect profile that's associated with them can interfere with adherence because they are given over a longer period of time. So we really do need improved therapeutics, especially in this patient population, because of some of these gaps. So let's talk about novel therapeutics for PPD. I want to start just giving an overview of some of the clinical trials that led to the FDA approval of brexanolone, which is the first FDA-approved first-in-class treatment in 2019. So this is a 60-hour infusion of synthetic allopregnanolone. And for the studies that were done, they were done in adult women who had an onset major depression, either in third trimester, the first 4 weeks after delivery, and we enrolled patients within 6 months of delivery. We randomized patients to brexanolone or placebo. And as you can see, this is a very rapid and very robust reduction of depressive symptoms because it was just over 60 hours. And you can see that the response was sustained for 30 days. One note is that as of January 1st of 2025, brexanolone will no longer be commercially available in the US. And these studies really led to the development of zuranolone, the first oral treatment for postpartum depression, the first oral neurosteroid treatment, which I'm going to tell you about next. Here we have the Skylark study, a phase 3 study of women with severe PPD in adults who were within a year of postpartum, and they were randomized to either 50 milligrams of oral zuranolone or placebo for 14 days. We also did a study at a slightly lower dose at 40 milligrams as well in adult women with severe PPD who were within 6 months postpartum. The two studies were almost identical except for those slight differences. And what we found were nearly identical results. So we saw that zuranolone was associated with, again, a rapid decrease in the depression total score. So we measured this as the Hamilton Depression Severity Total Score. And we looked from the change from baseline to day 15, which was just the next morning after the final dose, because it's an acute 14-day treatment course compared to placebo. We saw high response rates. And again, we saw a continuation of the response out to day 45. We also saw really similar curves for anxiety. And we know that anxiety can be quite comorbid in patients with PPD. And when we look at the remission rates in patients for both depression and anxiety, so in how many patients did zuranolone treatment push the depression and anxiety into remission, we see that at day 15, 40.5% of patients who received zuranolone had concurrent remission of depression and anxiety, and that increased even further out at day 45. These were really much more improved than those patients who received placebo. Now, the safety profile of zuranolone, it is a GABAergic medication. And so as you can probably predict, the most common side effect is somnolence. And the most common ones not only are somnolence, but also dizziness, diarrhea, fatigue, and urinary tract infection. But the lion's share of side effects are really in the somnolence and dizziness categories. We know that dose reduction due to an adverse reaction occurred in about 14% of zuranolone-treated patients. And again, somnolence and dizziness were the main reasons for that. So somnolence is one of those things we want to educate patients about and also think about, are patients taking anything else that could lead to somnolence? Because that might be exacerbated by zuranolone, might need a little bit lower dose just to make sure that that's not impairing for the patient. What's been exciting is that there are other studies that are starting on other therapeutics involving neurosteroids and PPD. This is one trial which is currently enrolling patients on clinicaltrials.gov, and it's an oral prodrug, which is hydrolyzed to brexanolone. So it's the same active ingredient in the FDA-approved medication indicated for PPD, but it's a prodrug. So it enhances oral absorption and prolongs half-life. And so this phase 2 study is currently recruiting and structured similarly to many of the other clinical trials in PPD. So it's really nice to know that there's additional therapeutic development in this area where it's so needed. Now let's talk about optimizing treatment at PPD and just really think about some practical considerations for clinicians in the OBGYN setting. So taking ACOG clinical practice guideline that was published in 2023, let's look at some of the recommendations regarding their general approach to pharmacotherapy. And so the ACOG recommendations are that obstetricians be prepared to counsel patients on the risks and benefits of medication when needed, but also that they initiate pharmacotherapy for perinatal depression or anxiety. And in certain patients, refer them to appropriate behavioral health resources when indicated or do both. Remember, I mentioned that when possible, start treatment as you're referring to the community rather than waiting to just refer, because then we have untreated disease. We talked about the recommendations of validated screening tools, but not just for screening, but to monitor for response and remission of depression or anxiety. You can use those to follow it, just like you would a blood pressure. And they're super helpful because then it gives you a number, right? You can really tell if the depression's improving or not. ACOG recommends that treatment for perinatal anxiety be equitable in its availability and accessibility as well. And then, a strong recommendation against withholding or discontinuing medication for mental health conditions due to pregnancy or lactation status alone. A good practice point, which I also agree with, is that OBGYNs should utilize their perinatal psychiatry access programs, which are available in many states as a resource for management and treatment guidance for peripartum individuals with mental health conditions. In addition, ACOG recommends psychotherapy as a first-line treatment for mild to moderate perinatal depression, and then adding a pharmacotherapy for moderate severe. They recommend that SSRIs can be a first-line pharmacotherapy for perinatal depression, and SNRIs are reasonable alternatives. This should be individualized based on if a patient has a prior response to therapy, but if there isn't, then starting in these categories are very reasonable. In addition, ACOG recommends consideration of zuranolone as a postpartum treatment. And so they define that within 12 months postpartum for depression that has an onset in third trimester or within 4 weeks of delivery. Other clinical pearls for the use of zuranolone is it's a 14-day course at 50 milligrams, and it can be reduced to 40 milligrams if there's too much somnolence. It can be used alone or as an adjunct to other oral antidepressant therapies like SSRIs or SNRIs. Patients should use effective contraception during the 14-day treatment course and for a week after the final dose. So again, it's only a postpartum treatment, and zuranolone may cause fetal harm. It has not been studied in pregnancy. Also, patients should be warned and given precautions about adverse reactions, including the boxed warning on an impaired ability to drive or engage in other potentially hazardous activities. Patients should not drive or engage in activities if they need complete mental alertness until at least 12 hours after each dose for the duration of the full treatment course. And so this is usually dosed at night around 8 p.m. so that patients, if they do need to drive in the morning, are able to do so later in the morning. Also, CNS depressant effects include somnolence and confusion. So this is where I talk about trying to look at the other medications that patients are taking. Definitely ask about any substance use or sedating substance use because you want to think about all the things at play. And then always monitor for suicidal ideation because this can happen during an episode of depression. Regarding breastfeeding during taking zuranolone does pass into the breast milk, although the relative dose is similar to or lower than that of SSRIs. Right now, however, there are no data on effects of zuranolone on a breastfed infant, and there's limited data on milk production. So the RID is less than 1%, which is well below the less than 10% RID threshold considered generally compatible with breastfeeding. And LACMed from the National Institutes of Health states if zuranolone is required by the mother, it's not a reason to discontinue breastfeeding. But because there's limited data at this time, because it's a newer medication, it should be used with careful infant monitoring for excessive sedation during breastfeeding, especially with higher doses or in newborn and preterm infants. And so as we do with all the medications we use during lactation, we really want to talk about the developmental and health benefits of breastfeeding, as well as the need to treat postpartum depression. And how do we think about, what to use for which patient? Here are some clinical considerations, and these are for moderate severe symptoms. For mild, moderate, and severe, we always try to engage patients with psychotherapy. But if she does present in pregnancy, then obviously the traditional antidepressants are to be used. Also, if a patient has a remission with a previous medication, to use that as well. Perhaps if there's mild, moderate functional impairment, or a patient does great in psychotherapy, there's low risk for suicide, or if there is active substance use that has a lot of risk for sedation, or in general substance use because these medications have not been studied in patients with active SUD. For zuranolone, consider its use in moderate severe symptoms or patient preference. Obviously, this is a postpartum treatment, not for patients who are actively trying to conceive. But think about for patients who had intolerability of prior antidepressants or failed an antidepressant during gestation, this could be added on the postpartum period as an adjunct. Especially for patients with moderate severe functional impairment, many of us in the field are optimizing its use, especially for patients who are having challenges of engaging in therapy or maybe at elevated risk for suicide as well. And where, we really want to bring down the depressive symptoms very quickly. And we know that the treatment and the decision in this patient population is complicated. Women need to weigh the perceived need for treatment against the risks and adverse effects. And this could be any of the effects of their treatments on the child, including exposure to medication when breastfeeding. But there are many other barriers that might reduce the patient's likelihood to seek or adhere to treatment for PPD. And some of those are listed here, including accessibility, cost of care, stigma, the fear of losing their child to child protective services comes up as well. And then there's time considerations, lack of support, and others. Shared decision-making is so important because it allows us to be in a dialogue around treatment options when there are multiple options to choose from. It includes education, risks and benefits. We want to make sure that individuals are active participants in their care and that we encourage the deliberation around the options and share information with our patients. Also, we want to have patients be able to articulate these treatment choices and their reasons for aligning with their needs and their values. This really allows a collaborative role when exploring mental health treatment options. And so part of that discussion is that, no decision regarding whether to use antidepressants during pregnancy is perfect or risk-free. We just have to really understand and consider both medication and non-medication options. Encourage the non-medication options, such as psychotherapies, in addition to medication treatment or an alternative when clinically appropriate. And we have to really balance and make sure our patients understand both the risks of antidepressant use during pregnancy, if the onset's during pregnancy, and the risks of undertreatment or delaying treatment during pregnancy. Many patients say, I don't want to start medication until after delivery. It's important that patients understand the risks with that decision as well. So in conclusion, ACOG recommends that all patients get screened for perinatal depression and anxiety, the initial prenatal visit, later pregnancy and at postpartum visits, that the use of a screen tool that is validated in the peripartum period be used. We do understand that all psychotropic medications pose some level of risk, whether that's in pregnancy or in lactation, and those risks greatly vary, whether it's during pregnancy or lactation. And that the provider and really the full team and patient should use shared decision-making to determine if the risks of pharmacotherapy outweigh the benefits of treatment. And zuranolone, a new FDA-approved medication, has a rapid onset for postpartum depression and is recommended by ACOG for consideration in the treatment of postpartum depression. Thank you.
Thank you for listening. Remember to download additional resources and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sage Therapeutics and Biogen. To access all materials for this activity, visit peerview.com/NCN860.